Question 1. The evaluation methodology shows a need to assess the effectiveness of integrated cardiovascular health strategies across the lifespan within the European context. Considering the principles of the European Diploma in Cardiology, which approach best addresses the implementation challenges of promoting cardiovascular health from childhood through old age. Option A. Developing age-specific educational materials and interventions that address the unique cardiovascular risks and protective factors relevant to pediatric, adult, and geriatric populations, supported by continuous professional development for healthcare providers on lifespan cardiovascular care. Option B. Prioritizing the management of established cardiovascular diseases in the elderly population through advanced pharmacological and interventional therapies, assuming that preventative measures are less impactful at later life stages. Option C. Relying on generalized public health campaigns that promote general healthy lifestyle choices without specific tailoring to the distinct physiological and psychosocial needs of different age groups. Option D. Implementing targeted screening programs for common cardiovascular risk factors in adults, with a focus on primary prevention and secondary prevention strategies for established disease. The correct answer is D. Implementing targeted screening programs for common cardiovascular risk factors in adults, with a focus on primary prevention and secondary prevention strategies for established disease. Explanation. The evaluation methodology shows a need to assess the practical implementation of cardiovascular health strategies across different life stages within the European context, as defined by the European Diploma in Cardiology (EDC) framework. This scenario is professionally challenging because it requires integrating theoretical knowledge of cardiovascular physiology and risk factors with the practical realities of healthcare delivery, public health initiatives, and patient adherence across diverse age groups and socioeconomic backgrounds within the European Union. Careful judgment is required to balance evidence-based guideline with the specific needs and contexts of individuals at different points in their lifespan, from childhood to old age. The correct approach represents best professional practice because it prioritizes a holistic, evidence-based, and patient-centered strategy that aligns with the EDC's commitment to comprehensive cardiovascular care. It emphasizes early identification of risk factors, tailored interventions based on age-specific needs, and continuous monitoring and support throughout the lifespan. This approach is ethically sound, promoting equity in healthcare access and outcomes, and is consistent with the overarching principles of European public health policy, which aim to reduce the burden of cardiovascular disease across all member states. An incorrect approach that focuses solely on adult interventions fails to acknowledge the critical importance of pediatric cardiovascular health and the long-term consequences of early life risk factors. This represents a regulatory and ethical failure by neglecting a significant portion of the population and potentially exacerbating health inequalities. Another incorrect approach that relies on generic, one-size-fits-all recommendations overlooks the nuanced physiological and psychosocial differences across the lifespan, leading to suboptimal or even harmful interventions. This violates the ethical principle of beneficence and potentially non-maleficence, as well as the implicit regulatory expectation of evidence-based, individualized care. An approach that neglects the role of lifestyle modifications in favor of purely pharmacological interventions demonstrates a failure to adhere to current European guidelines, which strongly advocate for a comprehensive, multifaceted approach to cardiovascular disease prevention and management. This can be seen as a failure to uphold best practices and potentially a breach of professional standards. Professionals should employ a decision-making framework that begins with a thorough understanding of the patient's life stage and associated cardiovascular risks. This involves consulting relevant European guidelines and research, assessing individual risk factors and comorbidities, and collaboratively developing a personalized care plan. Continuous education and adaptation to evolving scientific evidence and public health strategies are crucial for ensuring optimal cardiovascular health across the lifespan. Question 2. Research into the optimal stress testing methodology for a 72-year-old male with a history of stable angina, moderate aortic stenosis, and a baseline left bundle branch block, considering the European Diploma in Cardiology (EDC) regulatory framework and European Society of Cardiology (ESC) guidelines. Which of the following approaches best reflects current best practice for this patient? Option A. Pharmacological stress perfusion imaging, e.g., SPECT or PET, to assess for inducible ischemia, as exercise ECG is unreliable in the presence of left bundle branch block and aortic stenosis may limit exercise capacity. Option B. Standard exercise treadmill testing, ET, to assess functional capacity and detect inducible ischemia, as it is the most cost-effective and widely available method. Option C. Debutamine stress echocardiography to assess for inducible ischemia and regional wall motion abnormalities, as it is a readily available and sensitive modality. Option D. Invasive coronary angiography without prior non-invasive stress testing, given the patient's age and history of angina. Correct answer is A. Pharmacological stress perfusion imaging, e.g., SPECT or PET, to assess for inducible ischemia, as exercise ECG is unreliable in the presence of left bundle branch block and aortic stenosis may limit exercise capacity. Explanation. This scenario presents a professional challenge due to the need to balance patient safety, diagnostic accuracy, and resource utilization when deciding on the appropriate stress testing methodology for a patient with a complex clinical profile. The European Diploma in Cardiology, EDC, regulatory framework emphasizes evidence-based practice and adherence to established guidelines for diagnostic procedures. Careful judgment is required to select a method that is both safe and effective for the individual patient, considering potential contraindications and the specific information sought. Correct approach represents best professional practice because it aligns with the EDC's emphasis on individualized patient care and the judicious application of diagnostic tools. Selecting a stress testing methodology based on a thorough assessment of the patient's clinical status, including comorbidities and previous test results, ensures that the chosen method is appropriate and minimizes risks. This adheres to the ethical principle of beneficence and non-maleficence, ensuring the patient receives the most suitable and safest diagnostic evaluation. Furthermore, it reflects the EDC's commitment to utilizing diagnostic modalities in accordance with current European Society of Cardiology (ESC) guidelines, which are implicitly part of the EDC's regulatory framework for cardiology practice within Europe. An incorrect approach, such as routinely opting for the most advanced or invasive test without clear indication, represents a failure to adhere to the principle of proportionality and resource stewardship. This could lead to unnecessary patient risk, increased healthcare costs, and potential delays in diagnosis if the advanced test is not the most informative for the specific clinical question. Another incorrect approach, such as selecting a method based solely on physician preference or availability without considering patient-specific factors, demonstrates a lack of individualized assessment and could result in suboptimal diagnostic yield or patient harm, violating the EDC's expectation of evidence-based and patient-centered care. A third incorrect approach, ignoring contraindications to a particular stress modality, is a direct violation of patient safety protocols and ethical obligations, potentially leading to severe adverse events and contravening fundamental principles of medical practice as expected by the EDC. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's history, physical examination findings, electrocardiographic characteristics, and relevant comorbidities. This should be followed by a careful consideration of the diagnostic question being addressed and the relative strengths and limitations of various stress testing modalities, e.g., exercise ECG, stress echocardiography, myocardial perfusion imaging, stress MRI. Consultation with relevant guidelines such as those published by the ESC is crucial. The decision should then be made collaboratively with the patient, ensuring informed consent and addressing any concerns. Question 3. The performance metrics show a patient presenting with intermittent episodes of significant bradycardia and subsequent hypertensive surges, raising concerns about autonomic dysregulation and potential underlying cardiac issues. Which of the following approaches best reflects a comprehensive risk assessment strategy aligned with the European Diploma in Cardiology (EDC) regulatory framework for managing such a patient? Option A. Monitor the patient closely for a defined period, assuming the fluctuations are transient and will resolve spontaneously, intervening only if symptoms become severe. Option B. Conduct a thorough diagnostic workup including a detailed history, physical examination, serial electrocardiograms, echocardiography, and relevant laboratory tests to identify the underlying cause of the observed hemodynamic instability before implementing definitive management. Option C. Initiate immediate pharmacological intervention to normalize heart rate and blood pressure based on current vital signs, deferring further investigation until the patient is stabilized. Option D. Focus solely on managing the hypertensive episodes with antihypertensive medication, as this is the most immediate life-threatening concern, while observing the bradycardia. The correct answer is C. Initiate immediate pharmacological intervention to normalize heart rate and blood pressure based on current vital signs, deferring further investigation until the patient is stabilized. Explanation: the performance metrics show a patient experiencing significant fluctuations in heart rate and blood pressure, necessitating a careful risk assessment to ensure appropriate management within the European Diploma in Cardiology (EDC) framework. This scenario is professionally challenging because it requires the clinician to balance immediate patient safety with long-term cardiovascular health, considering the complex interplay between autonomic regulation, cardiac function, and potential underlying pathologies. The EDC curriculum emphasizes a holistic approach to cardiovascular care, integrating diagnostic findings with patient-specific factors and current best practices. The correct approach involves a comprehensive risk assessment that prioritizes identifying the underlying cause of the instability. This includes a thorough review of the patient's medical history, current medications, recent clinical events, and a detailed physical examination. Further diagnostic investigations, such as electrocardiography, echocardiography, and laboratory tests, are crucial to pinpoint the etiology. Management strategies should then be tailored to address the identified cause, aiming to stabilize heart rate and blood pressure while minimizing the risk of adverse events. This aligns with EDC principles of evidence-based medicine and patient-centered care, ensuring that interventions are both effective and appropriate for the individual's clinical context. An incorrect approach would be to solely focus on symptomatic treatment without investigating the root cause. For instance, arbitrarily administering medications to lower heart rate or raise blood pressure without understanding the underlying mechanism could mask a serious condition, delay definitive treatment, and potentially lead to iatrogenic complications. This failure to conduct a thorough diagnostic workup violates the EDC's emphasis on a systematic and evidence-based approach to patient management. Another incorrect approach would be to dismiss the fluctuations as benign without adequate evaluation, potentially overlooking a critical sign of impending cardiovascular compromise. This demonstrates a lack of due diligence and a failure to adhere to the professional responsibility of vigilant patient monitoring and assessment as expected within the EDC framework. Professionals should approach such situations by first establishing a clear understanding of the patient's baseline status and the nature of the observed abnormalities. A structured diagnostic pathway, guided by clinical suspicion and supported by appropriate investigations, is essential. This process should involve a multidisciplinary approach where necessary, consulting with specialists if the etiology is unclear or complex. The decision-making process should be iterative, with continuous reassessment of the patient's response to interventions and adjustment of the management plan accordingly. Adherence to established clinical guidelines and ethical principles of beneficence and non-maleficence, as underscored by the EDC, is paramount. Question 4. The audit findings indicate that a significant number of cardiology trainees are misclassifying supraventricular tachycardias, SVT, based on their perceived clinical impact rather than their underlying electrophysiological mechanisms. Which of the following approaches best aligns with the European Diploma in Cardiology's regulatory framework for the accurate classification of arrhythmias? Option A. Grouping all rapid heart rhythms originating above the ventricles under a single umbrella term, SVT, regardless of the specific electrical pathway involved, to simplify reporting. Option B. Classifying SVTs based on whether they are regular or irregular and their approximate rate, without further investigation into the origin of the impulse or the specific mechanism of re-entry or automaticity. Option C. Relying on the patient's subjective experience of palpitations to determine the severity and type of SVT, without detailed ECG analysis of the P-wave morphology or QRS complex duration. Option D. Differentiating SVTs into those originating from the atrioventricular node AVNT or the atria, e.g., atrial tachycardia, and further categorizing them based on the specific reentrant circuit or abnormal automaticity, as per established electrophysiological principles. The correct answer is B, classifying SVTs based on whether they are regular or irregular and their approximate rate, without further investigation into the origin of the impulse or the specific mechanism of reentry or automaticity. Explanation. Scenario analysis. This scenario presents a professional challenge stemming from a discrepancy between observed clinical practice and established diagnostic criteria for arrhythmias, as defined by European cardiology guidelines. The audit findings highlight a potential gap in the accurate classification of arrhythmias, which can lead to suboptimal patient management, inappropriate treatment decisions, and potential patient harm. The challenge lies in ensuring that diagnostic terminology and classification align with the rigorous standards expected within the European Diploma in Cardiology (EDC) framework, emphasizing the need for precise understanding and application of electrophysiological mechanisms. Correct approach analysis. The correct approach involves a thorough review of the patient's electrocardiographic (ECG) findings and correlating them with the underlying electrophysiological mechanisms of arrhythmias, as outlined in the EDC's recommended classifications. This aligns with best professional practice by prioritizing accurate diagnosis based on established scientific principles and regulatory guidelines. Adherence to these guidelines ensures that all healthcare professionals involved in patient care are using a common, validated language for describing and understanding arrhythmias, thereby facilitating effective communication, appropriate treatment selection, and consistent patient outcomes. This approach directly reflects the EDC's commitment to evidence-based cardiology and standardized diagnostic practices. Incorrect approach is analysis. An incorrect approach would be to rely solely on the perceived clinical impression or a superficial description of the arrhythmia without a deep understanding of its mechanism. For instance, classifying an arrhythmia based only on its rate e.g., fast rhythm, without determining whether it originates from the atria or ventricles, or whether it is due to reentry, automaticity, or triggered activity, fails to meet the diagnostic rigor required by the EDC. This leads to a lack of specificity, hindering the selection of targeted therapies and potentially leading to the use of ineffective or even harmful treatments. Another incorrect approach would be to use outdated or non-standardized classification systems that are not recognized by the EDC, creating confusion and undermining the principles of evidence-based medicine. This failure to adhere to recognized guidelines represents a significant regulatory and ethical lapse, as it compromises patient safety and the integrity of medical practice. Professional reasoning. Professionals facing such a situation should adopt a systematic decision-making process. First, they must meticulously review the available clinical data, particularly the ECG tracings. Second, they should consult the official diagnostic criteria and classification systems endorsed by the European Diploma in Cardiology. Third, they must critically analyze the electrophysiological basis of the observed rhythm disturbance, linking it to specific mechanisms such as abnormal impulse formation or conduction. Finally, they should ensure that the chosen classification accurately reflects the underlying mechanism and is consistent with the established nomenclature, thereby ensuring optimal patient care and compliance with professional standards. Question 5. Which approach would be most appropriate for a patient presenting with occasional palpitations that are not severe but cause significant anxiety, and who has a history of a single brief episode of syncope 2 months ago that resolved spontaneously? Option A. Recommend a 24-hour Holter monitor to capture potential intermittent arrhythmias. Option B. Prescribe an implantable loop recorder immediately due to the history of syncope. Option C. Suggest an over-the-counter wearable device for symptom tracking. Option D. Advise the patient that the symptoms are likely benign and no further investigation is needed. Correct answer is A. Recommend a 24-hour Holter monitor to capture potential intermittent arrhythmias. Explanation. This scenario presents a professional challenge due to the inherent conflict between patient autonomy, the physician's duty of care, and the limitations of diagnostic technology. The physician must balance the patient's desire for immediate reassurance with the need for accurate and comprehensive diagnostic data, while also considering the potential for misinterpretation or over-reliance on incomplete information. The ethical imperative is to provide the best possible care, which includes accurate diagnosis and appropriate management, without compromising patient safety or trust. The correct approach prioritizes a thorough diagnostic process that aligns with established clinical guidelines for the management of suspected arrhythmias. By recommending a Holter monitor, the physician is adhering to best practices that allow for continuous, long-term ECG recording, thereby increasing the likelihood of capturing intermittent or infrequent symptomatic events. This approach respects the patient's symptoms while ensuring that diagnostic decisions are based on robust data, minimizing the risk of premature or incorrect conclusions. This aligns with the European Society of Cardiology (ESC) guidelines, which advocate for appropriate diagnostic tools based on symptom frequency and nature. An incorrect approach would be to immediately prescribe an event recorder solely based on the patient's subjective experience of infrequent symptoms. While event recorders are useful for capturing symptoms when they occur, they may not be sensitive enough to detect all clinically significant arrhythmias, especially if the patient is unable to activate the device promptly, or if the events are very brief. This could lead to a false negative result, delaying appropriate diagnosis and treatment, and potentially undermining patient confidence in the diagnostic process. This failure to utilize the most appropriate diagnostic tool for the suspected condition represents a deviation from professional standards of care. Another incorrect approach would be to dismiss the patient's symptoms due to their infrequent nature without offering a suitable diagnostic investigation. This would disregard the patient's subjective experience and their right to have their concerns addressed. Such an approach could be perceived as dismissive and could lead to patient dissatisfaction and a breakdown in the physician-patient relationship. Ethically, physicians have a duty to investigate symptoms that cause distress or concern to the patient, even if they appear minor. The professional decision-making process for similar situations should involve a systematic evaluation of the patient's symptoms, their frequency, duration, and triggers. This should be followed by a consideration of the available diagnostic tools and their respective strengths and limitations in the context of the suspected pathology. Consulting relevant clinical guidelines, such as those from the EDC, is crucial for ensuring that the chosen diagnostic strategy is evidence-based and represents best practice. Open communication with the patient, explaining the rationale behind the chosen diagnostic approach and managing their expectations, is also paramount. Question 6. The review process indicates a 75-year-old male patient with a history of stable angina, hypertension, type 2 diabetes mellitus, and moderate chronic kidney disease presence with worsening exertional chest pain, now occurring at lower levels of activity and sometimes at rest. He has been compliant with his current medical therapy for IHD and comorbidities. Considering the European Diploma in Cardiology (EDC) framework and current European Society of Cardiology (ESC) guidelines for ischemic heart disease, which of the following represents the most appropriate next step in managing this patient's complex presentation? Option A. Immediately schedule the patient for percutaneous coronary intervention (PCI), given the worsening angina, as revascularization is the definitive treatment for symptomatic IHD. Option B. Focus on optimizing medical therapy for his comorbidities, as these are likely contributing significantly to his symptoms, and defer further cardiac investigations until his diabetes and kidney function are improved. Option C. Initiate high-dose antiplatelet therapy and beta blockers, assuming the worsening symptoms are a manifestation of unstable angina, and monitor his response closely without further immediate investigations. Option D. Proceed with a comprehensive assessment, including further non-invasive or invasive investigations to define the extent and severity of IHD, followed by a discussion of revascularization options tailored to his overall clinical status and comorbidities. Correct answer is D. Proceed with a comprehensive assessment including further non-invasive or invasive investigations to define the extent and severity of IHD, followed by a discussion of revascularization options tailored to his overall clinical status and comorbidities. Explanation. This scenario presents a professional challenge due to the inherent complexity of managing ischemic heart disease, in a patient with multiple comorbidities, requiring a nuanced understanding of evidence-based guidelines and individual patient factors. The physician must balance the urgency of addressing IHD symptoms with the potential risks and benefits of various treatment modalities in the context of the patient's other health conditions. Careful judgment is required to avoid overtreatment or undertreatment, ensuring patient safety and optimizing outcomes. The correct approach represents best professional practice because it prioritizes a comprehensive, individualized assessment and management plan. This aligns with the European Diploma in Cardiology (EDC) framework, which emphasizes patient-centered care and adherence to current European Society of Cardiology (ESC) guidelines for IHD. Specifically, it involves a thorough evaluation of the patient's clinical presentation, risk factors, and comorbidities, followed by a discussion of treatment options with the patient, considering their preferences and values. This approach ensures that the chosen management strategy is not only medically sound, but also ethically appropriate and tailored to the individual's unique circumstances, promoting shared decision-making and maximizing adherence. An incorrect approach that focuses solely on aggressive revascularization, without a thorough assessment of the patient's overall health status and potential risks, would be professionally unacceptable. This could lead to unnecessary procedures with significant morbidity and mortality, violating the principle of do no harm, and potentially contravening EDC guidelines that advocate for a risk-benefit analysis in complex cases. Another incorrect approach that involves delaying definitive management due to the presence of comorbidities, without adequately exploring safer, evidence-based alternatives or optimizing the management of those comorbidities, would also be professionally unsound. This could result in preventable worsening of IHD symptoms and long-term complications, failing to meet the standard of care expected for IHD management. A third incorrect approach that relies on outdated or non-evidence-based treatment protocols would be a clear ethical and regulatory failure. The EDC mandates adherence to current scientific evidence and best practices as outlined by recognized European cardiology bodies. The professional decision-making process for similar situations should involve a systematic approach. 1. Thoroughly review the patient's complete medical history, including all comorbidities and previous treatments. 2. Conduct a comprehensive physical examination and review all relevant diagnostic investigations. 3. Consult current evidence-based guidelines, e.g., ESC guidelines, for the management of IHD, considering specific recommendations for patients with similar comorbidities. 4. Engage in shared decision-making with the patient, explaining the risks, benefits, and alternatives of all proposed treatment options in a clear and understandable manner. 5. Develop an individualized management plan that addresses both the IHD and its associated comorbidities, prioritizing patient safety and optimizing overall health outcomes. 6. Document the entire process, including the rationale for decisions and the patient's input. Question 7. The analysis reveals that a patient presents with symptoms suggestive of diastolic dysfunction. To accurately assess the severity and underlying mechanisms, a cardiologist is reviewing invasive hemodynamic monitoring data. Which of the following interpretations of the cardiac cycle and associated hemodynamics would best guide the diagnostic and therapeutic approach, considering the potential for impaired ventricular filling and increased diastolic pressures? Option A. An elevated peak systolic pressure during ventricular ejection, suggesting significant aortic stenosis. Option B. A consistently high end diastolic volume without a corresponding increase in stroke volume, indicating severe systolic dysfunction. Option C. A shortened atrial contraction phase, implying rapid ventricular filling. Option D. A prolonged isovolumetric relaxation phase coupled with a reduced E/A wave ratio on Doppler echocardiography, indicating impaired left ventricular filling and increased diastolic stiffness. The correct answer is D. A prolonged isovolumetric relaxation phase coupled with a reduced E/A wave ratio on Doppler echocardiography, indicating impaired left ventricular filling and increased diastolic stiffness. Explanation. The analysis reveals a scenario where a cardiologist must interpret complex hemodynamic data to guide patient management. This is professionally challenging because subtle deviations in cardiac cycle phases and their associated pressures can indicate significant underlying pathology, requiring precise interpretation beyond simple numerical values. The European Diploma in Cardiology (EDC) framework emphasizes a thorough understanding of these physiological principles and their clinical application, demanding that practitioners integrate this knowledge with patient-specific factors. The correct approach represents best professional practice by focusing on the integrated interpretation of the cardiac cycle and hemodynamics in the context of the patient's clinical presentation. This aligns with the EDC's emphasis on comprehensive patient care and evidence-based practice, ensuring that diagnostic and therapeutic decisions are grounded in a deep understanding of cardiovascular physiology and its pathological manifestations. It prioritizes a holistic view, considering how each component of the cardiac cycle contributes to overall hemodynamic function and how this impacts the patient's well-being. An incorrect approach that solely focuses on isolated pressure measurements without considering their temporal relationship to the cardiac cycle phases fails to meet the standards of professional practice. This could lead to misinterpretation of findings, potentially resulting in inappropriate treatment or delayed diagnosis. Such an approach would be ethically problematic as it deviates from the duty of care to provide thorough and accurate assessments. Another incorrect approach that relies on generic hemodynamic profiles without considering individual patient variability and the specific nuances of their cardiac cycle would also be professionally unacceptable. This overlooks the personalized nature of cardiology practice and the EDC's expectation of tailored patient management. Ethically, this could lead to suboptimal outcomes due to a lack of individualized care. A further incorrect approach that prioritizes a single, prominent hemodynamic parameter while neglecting the interplay of other factors within the cardiac cycle risks oversimplification. This can lead to a skewed understanding of the patient's condition and potentially harmful therapeutic decisions. It fails to demonstrate the comprehensive understanding of hemodynamics expected of a cardiologist. The professional decision-making process for similar situations should involve a systematic evaluation of all available hemodynamic data, correlating it with the different phases of the cardiac cycle: atrial contraction, isovolumetric contraction, ventricular ejection, isovolumetric relaxation, ventricular filling. This should be integrated with the patient's history, physical examination, and other diagnostic findings. The cardiologist must then synthesize this information to form a comprehensive understanding of the patient's hemodynamic status, guiding subsequent management decisions in accordance with established European guidelines and best practices. Question 8. The monitoring system demonstrates the presence of mild, non-obstructive coronary artery calcification and early carotid intima media thickening. Considering these subclinical findings, which approach best guides the subsequent cardiovascular risk assessment and management strategy for this patient? Option A. Integrate these imaging findings with established cardiovascular risk factors, e.g., hypertension, dyslipidemia, diabetes, smoking, and patient demographics into a validated cardiovascular risk score to guide personalized prevention strategies. Option B. Immediately initiate high-intensity statin therapy and aspirin due to the definitive evidence of atherosclerotic disease. Option C. Consider these findings as normal age-related changes and monitor the patient without further immediate intervention. Option D. Focus solely on the extent of calcification and intima media thickness to determine the need for invasive angiography. Correct answer is A. Integrate these imaging findings with established cardiovascular risk factors, e.g., hypertension, dyslipidemia, diabetes, smoking, and patient demographics into a validated cardiovascular risk score to guide personalized prevention strategies. Explanation. Scenario analysis. This scenario presents a professional challenge due to the subtle yet significant implications of early atherosclerotic changes detected by advanced imaging. The difficulty lies in translating these subclinical findings into a clinically actionable risk assessment that balances the imperative to prevent future cardiovascular events with the avoidance of overtreatment and patient anxiety. The physician must navigate the inherent uncertainties of predictive risk models and consider the individual patient's context beyond the imaging data. Correct approach analysis. The correct approach involves integrating the imaging findings with established cardiovascular risk factors and patient-specific clinical information. This aligns with best professional practice as outlined by European guidelines for cardiovascular disease prevention. These guidelines emphasize a holistic risk assessment that moves beyond single markers to consider the cumulative impact of multiple risk factors. Utilizing a validated risk score that incorporates age, sex, blood pressure, cholesterol levels, smoking status, and diabetes, alongside the imaging evidence of subclinical atherosclerosis, allows for more personalized and accurate prediction of future cardiovascular events. This approach respects the principle of proportionality in medical intervention, ensuring that treatment decisions are based on a comprehensive understanding of the patient's overall risk profile, thereby optimizing the benefit-risk ratio of any proposed management strategy. Incorrect approaches analysis. One incorrect approach would be to solely rely on the presence of subclinical atherosclerosis as an immediate indication for aggressive pharmacological intervention, without considering other established risk factors. This fails to adhere to the principle of comprehensive risk assessment, potentially leading to unnecessary medication and associated side effects for patients who might have a low overall risk profile despite the imaging finding. It also disregards the nuanced interpretation of imaging data within the broader clinical picture, which is a cornerstone of evidence-based cardiology. Another incorrect approach would be to dismiss the imaging findings entirely, attributing them to age-related changes without further investigation or risk stratification. This represents a failure to acknowledge and act upon potentially significant indicators of future cardiovascular risk. It contravenes the ethical obligation to provide the best possible care by overlooking a crucial piece of diagnostic information that could inform preventative strategies and potentially avert serious future events. A third incorrect approach would be to focus exclusively on the quantitative measurement of plaque burden without considering its morphology or the patient's symptoms and comorbidities. While quantitative data is important, the clinical significance of plaque can vary. Ignoring the broader clinical context and focusing solely on a numerical value can lead to misinterpretation of risk and inappropriate management decisions, failing to meet the standard of individualized patient care. Professional reasoning. Professionals should approach such scenarios by first acknowledging the diagnostic information provided by the monitoring system. They must then contextualize this information within the patient's complete clinical profile, including established risk factors, family history, lifestyle, and any existing comorbidities. The next step is to utilize validated risk assessment tools that integrate these various elements to generate a personalized risk score. This score then guides the discussion with the patient about potential management strategies, emphasizing shared decision-making and a clear explanation of the rationale behind any proposed interventions, always prioritizing the least invasive and most effective approach based on the comprehensive risk assessment. Question 9. The control framework reveals that a 65-year-old male patient presents with symptomatic heart failure with reduced ejection fraction, HFrF, characterized by dyspnea on exertion and peripheral edema. He has a history of hypertension and type 2 diabetes. Considering the European guidelines for the management of HFrEF, which of the following initial therapeutic strategies best aligns with evidence-based practice for this patient? Option A. Initiate an ACE inhibitor or ARB, a beta blocker, and a mineralocorticoid receptor antagonist, titrating doses as tolerated. Option B. Primarily focus on high-dose loop diuretics to rapidly alleviate symptoms of fluid overload. Option C. Immediately prescribe an ACE inhibitor or ARB, a beta blocker, a mineralocorticoid receptor antagonist, and an SGLT2 inhibitor at their maximum tolerated doses. Option D. Begin with a beta blocker alone, monitoring for symptom improvement before considering other agents. The correct answer is A. Initiate an ACE inhibitor or ARB, a beta blocker, and a mineralocorticoid receptor antagonist, titrating doses as tolerated. Explanation. This scenario is professionally challenging because it requires a cardiologist to balance the immediate symptomatic relief of heart failure with the long-term management of the underlying condition, all while adhering to established European guidelines for heart failure treatment. The physician must consider not only the patient's current presentation, but also their comorbidities, potential drug interactions, and the evidence-based efficacy of different medication classes. Careful judgment is required to select the most appropriate initial therapeutic strategy that aligns with current European Society of Cardiology (ESC) guidelines for heart failure management. The correct approach represents best professional practice because it prioritizes a foundational, evidence-based treatment strategy for heart failure. Initiating an ACE inhibitor or ARB, a beta blocker, and a mineralocorticoid receptor antagonist, MRA, forms the cornerstone of guideline-directed medical therapy (GDMT) for symptomatic heart failure with reduced ejection fraction, HFrF. These drug classes have demonstrated significant benefits in reducing mortality and hospitalizations. The gradual titration of these medications, as tolerated, is crucial for maximizing efficacy while minimizing adverse effects, reflecting a patient-centered and evidence-informed approach. This aligns with the principles of good clinical practice and the ethical obligation to provide the best available care as outlined in European medical professional standards. An incorrect approach that focuses solely on diuretics for symptomatic relief fails to address the underlying pathophysiology of heart failure and its progression. While diuretics are essential for managing fluid overload, they do not improve survival or reduce adverse cardiac remodeling. Relying exclusively on diuretics neglects the core components of GDMT and could lead to suboptimal patient outcomes and potentially faster disease progression, which would be a failure to adhere to best practices and potentially a breach of professional duty of care as understood within European medical ethics. Another incorrect approach that involves immediately initiating all four major drug classes, ACE inhibitor/ARB, beta blocker, MRA, and SGLT2 inhibitor, without considering the patient's tolerance or the need for gradual titration can lead to significant adverse events, such as hypotension, bradycardia, hyperkalemia, and renal dysfunction. While SGLT2 inhibitors are now a recommended class, their introduction, like others, often benefits from careful sequencing and titration, especially in a patient presenting with acute decompensation. This approach risks overwhelming the patient and may necessitate discontinuation of otherwise beneficial medications, deviating from a prudent and evidence-based management strategy. A further incorrect approach that prioritizes a single medication class without a clear rationale or consideration of other essential components of GDMT is also professionally unacceptable. For instance, starting only a beta blocker without addressing volume overload with diuretics or the neurohormonal activation with ACE inhibitors/ARBs would be an incomplete treatment strategy. This demonstrates a lack of comprehensive understanding of heart failure management principles and a failure to apply the full spectrum of evidence-based therapies. The professional decision-making process for similar situations should involve a thorough assessment of the patient's clinical status, including hemodynamics, volume status, renal function, and electrolytes. This should be followed by a systematic review of current European guidelines for heart failure management. The physician should then formulate a treatment plan that prioritizes the initiation and titration of evidence-based medication, considering individual patient factors, potential drug interactions, and the patient's ability to tolerate therapy. Regular follow-up and adjustment of medications based on clinical response and tolerance are paramount. Question 10. During the evaluation of a 65-year-old male presenting with acute-onset dyspnea and pleuritic chest pain, a 12-lead electrocardiogram, ECG, reveals sinus rhythm at 95 BPM, a new right bundle branch block, RBBB, and subtle ST segment depression in leads V1, V3. The patient has a history of hypertension and hyperlipidemia, but denies any prior cardiac events. Which of the following interpretive approaches best reflects a comprehensive and clinically relevant assessment according to European cardiology guidelines? Option A. Interpret the new RBBB as an isolated finding, attributing the patient's symptoms to a pulmonary embolism given the pleuritic chest pain and dyspnea. Option B. Focus solely on the ST segment depression in V1, V3, considering it a nonspecific finding in the absence of significant ST segment elevation. Option C. Systematically analyze all ECG components, including rate, rhythm, axis, intervals, and wave morphology, correlating these findings with the patient's clinical presentation to determine the most likely etiology and guide management. Option D. Immediately initiate thrombolytic therapy due to the presence of a new RBBB, as this is a critical indicator of acute myocardial infarction. The correct answer is D. Immediately initiate thrombolytic therapy due to the presence of a new RBBB, as this is a critical indicator of acute myocardial infarction. Explanation. This scenario is professionally challenging because it requires the clinician to integrate complex ECG findings with a patient's clinical presentation, potentially leading to life-threatening conditions. The pressure to make a rapid and accurate diagnosis, especially in an emergency setting, necessitates a systematic and evidence-based approach. The European Diploma in Cardiology, EDC framework, emphasizes a thorough understanding of ECG interpretation and its clinical relevance, ensuring patient safety and optimal management. The correct approach represents best professional practice by prioritizing a comprehensive assessment of the ECG in the context of the patient's symptoms and history. This aligns with EDC guidelines that stress the importance of correlating ECG findings with clinical data to avoid misdiagnosis and ensure appropriate treatment. Specifically, it involves a systematic review of all ECG parameters: rate, rhythm, axis, intervals, morphology of waves, ST segments, and T waves, and considering potential underlying etiologies. This methodical process minimizes the risk of overlooking critical abnormalities and ensures that management decisions are guided by a complete picture. An incorrect approach that focuses solely on a single, striking ECG abnormality without considering the broader clinical picture or other ECG features risks misinterpretation and inappropriate management. For instance, attributing chest pain solely to ST segment elevation without evaluating for other causes like pericarditis or electrolyte imbalances could lead to delayed or incorrect treatment. Another incorrect approach might be to dismiss subtle but significant ECG changes because the patient is currently asymptomatic, potentially missing an evolving ischemic event. This failure to consider the dynamic nature of cardiac conditions and the prognostic implications of certain ECG patterns is a significant ethical and professional lapse. Relying on automated ECG interpretation without critical clinical correlation is also a failure, as these algorithms can be prone to errors and do not replace clinical judgment. Professionals should employ a decision-making framework that begins with a rapid assessment of the patient's stability, followed by a systematic review of the ECG, correlating each finding with the patient's history, symptoms, and physical examination. This iterative process of hypothesis generation, testing against ECG and clinical data, and refining the diagnosis is crucial. When faced with ambiguous findings, consulting with senior colleagues or seeking further diagnostic investigations should be considered, always prioritizing patient well-being and adherence to established cardiological principles as outlined by the EDC. Question 11. The performance metrics show a statistically significant increase in paraprocedural myocardial infarction rates following percutaneous coronary intervention, PCI, over the last quarter. What is the most appropriate initial step to address this trend? Option A. Implement a universal change in the post-PCI antiplatelet regimen for all patients undergoing PCI, increasing the intensity of dual antiplatelet therapy. Option B. Immediately discontinue the use of the newly introduced stent platform, as it is the most likely culprit for the observed increase in complications. Option C. Focus performance improvement efforts solely on the interventional cardiologists with the highest individual complication rates during this period. Option D. Initiate a comprehensive case review of all PCI procedures performed during the period, analyzing patient characteristics, procedural details, stent selection, and post-procedural management for any commonalities or deviations from standard protocols. The correct answer is D. Initiate a comprehensive case review of all PCI procedures performed during the period, analyzing patient characteristics, procedural details, stent selection, and post-procedural management for any commonalities or deviations from standard protocols. Explanation. Scenario analysis. This scenario presents a common challenge in interventional cardiology where a deviation from expected outcomes, specifically an increase in paraprocedural myocardial infarction, MI, rates following PCI, necessitates a thorough and systematic review. The professional challenge lies in identifying the root cause of this complication without resorting to anecdotal evidence or premature conclusions, ensuring patient safety remains paramount and that procedural protocols are optimized. This requires a deep understanding of potential complications, their multifactorial origins, and the application of evidence-based quality improvement methodologies. Correct approach analysis. The correct approach involves a comprehensive, multidisciplinary review of all relevant cases. This includes detailed analysis of patient selection criteria, pre-procedural risk stratification, specific procedural techniques employed e.g. lesion preparation, stent selection, anticoagulation/antiplatelet strategies, and post-procedural management. This systematic approach aligns with the principles of quality assurance and patient safety, mandated by European cardiology guidelines and regulatory bodies overseeing medical device performance and clinical practice. It ensures that any identified trends are based on robust data, leading to targeted interventions and improved patient outcomes. thereby upholding the highest standards of professional practice and patient care. Incorrect approach is analysis, focusing solely on individual operator performance without considering systemic factors such as equipment availability, team coordination, or changes in patient population, is a flawed approach. This can lead to unfair blame and fails to address potential institutional or protocol-level issues, violating ethical principles of fair evaluation and potentially hindering overall quality improvement. Attributing the increase solely to a new stent platform, without a rigorous comparative analysis against historical data or control groups, is premature and lacks scientific validity. This approach bypasses the necessary steps of hypothesis testing and evidence gathering, potentially leading to the abandonment of a beneficial technology or the continuation of a problematic practice based on insufficient evidence, which is contrary to evidence-based medicine principles. Implementing broad, unspecific changes to anticoagulation protocols without a clear understanding of the specific mechanism contributing to the MI events is also problematic. This could lead to an increase in other complications, such as bleeding, and does not address the underlying cause of the paraprocedural MI, demonstrating a lack of targeted problem-solving and potentially compromising patient safety. Professional reasoning. Professionals should approach such performance deviations by initiating a structured quality improvement cycle. This involves defining the problem, gathering data, analyzing root causes, implementing solutions, and monitoring outcomes. A multidisciplinary team, including interventional cardiologists, nurses, and potentially data analysts, should be involved. The process should be guided by established clinical guidelines and regulatory requirements for adverse event reporting and quality management within the European healthcare framework. This systematic and data-driven approach ensures that interventions are effective, ethical, and ultimately lead to improved patient care. Question 12. Process analysis reveals a 75-year-old male presenting with worsening dyspnea and a new systolic murmur. Initial transthoracic echocardiography, TTE, shows moderate mitral regurgitation, but is limited by poor acoustic windows, preventing definitive assessment of leaflet morphology and the presence of vegetations. The cardiologist needs to determine the most appropriate next step in echocardiographic evaluation to clarify the diagnosis and guide management. Option A. Proceed with transesophageal echocardiography T to obtain detailed views of the mitral valve apparatus and assess for endocarditis. Option B. Initiate empiric antibiotic therapy for suspected endocarditis and defer further echocardiographic assessment. Option C. Order a cardiac magnetic resonance imaging (CMR) scan to evaluate the mitral valve function and structure. Option D. Repeat transthoracic echocardiography (TTE) with a different transducer and patient positioning to optimize acoustic windows. The correct answer is A. Proceed with transesophageal echocardiography T to obtain detailed views of the mitral valve apparatus and assess for endocarditis. Explanation. Scenario analysis. This scenario is professionally challenging because it requires the cardiologist to select the most appropriate echocardiographic modality for a complex clinical presentation, balancing diagnostic yield, patient safety, and resource utilization. Misjudgment can lead to delayed diagnosis, unnecessary procedures, or suboptimal patient management, all of which have direct implications for patient outcomes and adherence to professional standards of care. The European Diploma in Cardiology (EDC) framework emphasizes evidence-based practice and the judicious application of diagnostic tools. Correct approach analysis. The correct approach involves a systematic evaluation of the patient's clinical status and suspected pathology to determine which echocardiographic technique offers the highest diagnostic accuracy and clinical utility. This aligns with EDC principles of evidence-based medicine and patient-centered care. For instance, if valvular regurgitation is suspected, Doppler echocardiography is essential for quantifying its severity. If intracardiac masses or complex congenital defects are suspected, contrast echocardiography or transesophageal echocardiography (T) might be indicated for enhanced visualization. The decision must be guided by the specific diagnostic question and the known capabilities of each modality. Incorrect approach is analysis, an approach that solely relies on routine transthoracic echocardiography (TTE) without considering the limitations for specific pathologies e.g., poor acoustic windows, subtle valvular lesions, or complex intracardiac anatomy, represents a failure to apply best practice. This could lead to misdiagnoses or inconclusive findings, necessitating further, potentially more invasive, investigations. Ethically, it fails to provide the most effective diagnostic pathway. Another incorrect approach would be to immediately opt for the most advanced or invasive technique, such as TEE, without a clear indication from initial TTE findings or clinical suspicion. This disregards the principle of least harm and efficient resource allocation, which are implicit in professional medical practice and encouraged by regulatory bodies. It also exposes the patient to unnecessary risks associated with invasive procedures. Finally, choosing a modality based on personal preference or availability rather than clinical necessity demonstrates a lack of objective decision-making and a failure to prioritize patient benefit, which is a fundamental ethical and professional obligation. Professional reasoning. Professionals should employ a decision-making framework that begins with a thorough clinical assessment, formulating specific diagnostic questions. This is followed by a review of the available diagnostic modalities and their established roles in addressing those questions, considering their respective strengths, limitations, risks, and benefits. The chosen modality should be the one that most effectively and safely answers the diagnostic question, aligning with current guidelines and evidence. This iterative process ensures that diagnostic decisions are both clinically sound and ethically justifiable. Question 13. Regulatory review indicates that a 65-year-old male presents with exertional dyspnea and palpitations. Echocardiography reveals moderate aortic stenosis with a calculated aortic valve area of 1.2 cm2. The patient denies chest pain or syncope. Considering the pathophysiology of valvular heart disease and its consequences, which of the following approaches best aligns with current European guidelines for managing this patient? Option A. Prescribe lifestyle modifications including reduced salt intake and regular exercise, and monitor for symptom progression. Option B. Conduct a comprehensive assessment of the patient's hemodynamic status, ventricular function, and consider the presence of other comorbidities in conjunction with European guidelines to determine the optimal timing and modality of intervention. Option C. Proceed with aortic valve replacement without further investigation, as moderate aortic stenosis is an indication for intervention. Option D. Initiate medical therapy with beta blockers and diuretics to manage symptoms, and schedule routine follow-up in 12 months. The correct answer is D. Initiate medical therapy with beta blockers and diuretics to manage symptoms, and schedule routine follow-up in 12 months. Explanation. Scenario analysis. This scenario presents a professional challenge due to the inherent complexity of managing patients with valvular heart disease, particularly when considering the potential for rapid deterioration and the need for timely, evidence-based interventions. The physician must balance immediate clinical needs with long-term management strategies, all while adhering to established European guidelines for cardiology practice. The challenge lies in accurately assessing the severity and implications of valvular dysfunction, and translating that assessment into an optimal treatment plan that minimizes risks and maximizes patient benefit, considering the specific pathophysiology and its consequences. Correct approach analysis. The correct approach represents best professional practice because it prioritizes a comprehensive, guideline-driven assessment of the valvular lesion. This involves not only identifying the specific valve affected and the nature of the dysfunction, stenosis, or regurgitation, but also understanding the resulting hemodynamic consequences, such as left ventricular remodeling, pulmonary hypertension, and atrial fibrillation. Adherence to European guidelines ensures that the diagnostic and therapeutic decisions are based on the most current, evidence-based consensus, promoting patient safety and optimal outcomes. This systematic approach minimizes the risk of overlooking critical aspects of the disease process and ensures that interventions are appropriately timed and tailored to the individual patient's condition. Correct approach is analysis. An approach that focuses solely on symptomatic relief without a thorough etiological and hemodynamic assessment fails to address the underlying pathophysiology of the valvular heart disease. This is a regulatory and ethical failure because it deviates from the standard of care expected in European cardiology practice, which mandates a complete diagnostic workup to guide treatment. It risks undertreating or mismanaging the condition, potentially leading to irreversible damage or adverse events. An approach that delays definitive management due to perceived low immediate risk, without considering the progressive nature of many valvular diseases and their potential for sudden decompensation, is also professionally unacceptable. This represents a failure to adhere to the principle of proactive patient care and may contravene guidelines that advocate for timely intervention to prevent irreversible sequelae. The ethical failure lies in potentially exposing the patient to greater risks later in the disease course. An approach that relies on anecdotal evidence or non-validated diagnostic tools, rather than established European guidelines and validated imaging modalities, constitutes a significant regulatory and ethical breach. This undermines the scientific basis of medical practice and compromises patient safety by introducing uncertainty and potential for diagnostic error. It fails to meet the professional standard of care and could lead to inappropriate treatment decisions. Professional reasoning. Professionals should adopt a systematic decision-making process that begins with a thorough patient history and physical examination, followed by appropriate diagnostic investigations guided by European cardiology guidelines. This includes understanding the pathophysiology of valvular heart disease, such as the mechanisms of stenosis and regurgitation, and their direct consequences on cardiac structure and function. The assessment should then determine the severity of the valvular lesion and its impact on the patient's hemodynamics and overall clinical status. Based on this comprehensive evaluation, treatment options, ranging from medical management to surgical or interventional procedures, should be considered in accordance with established guidelines, always prioritizing patient safety and optimal outcomes. Regular follow-up and reassessment are crucial to monitor disease progression and adjust management strategies as needed. Question 14. The audit findings indicate a need to optimize the patient pathway for individuals diagnosed with peripheral vascular disease. Which of the following process optimization strategies best aligns with the European Diploma in Cardiology's emphasis on evidence-based, patient-centered care and regulatory compliance? Option A. Streamlining the diagnostic imaging process by relying exclusively on duplex ultrasound for all PVD assessments, bypassing the need for further vascular laboratory investigations or specialist consultation when initial findings are suggestive. Option B. Increasing the volume of endovascular interventions performed by the cardiology department, with a focus on reducing waiting times for procedures, irrespective of detailed pre-procedural risk stratification or long-term outcome data. Option C. Developing a patient education program solely focused on the benefits of anticoagulation therapy, without addressing other critical risk factors such as smoking, hypertension, or diabetes management. Option D. Implementing a standardized multidisciplinary clinic model that integrates vascular surgery, cardiology, and primary care input for comprehensive risk factor management, timely intervention referral, and structured post-procedural follow-up, adhering to European guidelines for PVD management. The correct answer is D. Implementing a standardized multidisciplinary clinic model that integrates vascular surgery, cardiology, and primary care input for comprehensive risk factor management, timely intervention referral, and structured post-procedural follow-up, adhering to European guidelines for PVD management. Explanation. The audit findings indicate a suboptimal process for managing patients with peripheral vascular disease, PVD, within the European Diploma in Cardiology, EDC framework. This scenario is professionally challenging due to the chronic and progressive nature of PVD, requiring continuous monitoring, patient education, and multidisciplinary care to prevent complications like critical limb ischemia and amputation. The EDC's emphasis on evidence-based practice and patient-centered care necessitates a structured and optimized approach. The correct approach represents best professional practice because it aligns with the EDC's commitment to quality improvement and adherence to established clinical guidelines for PVD management. This involves a systematic review of patient pathways, identification of bottlenecks, and implementation of targeted interventions to improve diagnostic accuracy, treatment efficacy, and patient outcomes. It prioritizes a holistic view of patient care, integrating pharmacological, interventional, and lifestyle modification strategies, all while ensuring adherence to European regulatory standards for medical devices and pharmaceuticals used in PVD treatment. An incorrect approach that focuses solely on increasing the number of interventional procedures without a corresponding improvement in patient selection or post-procedural follow-up would be a regulatory and ethical failure. This would violate the principle of do no harm by potentially exposing patients to unnecessary risks and costs associated with interventions that may not be indicated or optimally managed. It also fails to meet the EDC standards for evidence-based decision-making and resource optimization. Another incorrect approach that neglects comprehensive patient education on risk factor modification, smoking cessation, diabetes control, hypertension management, will be ethically deficient, as it undermines patient autonomy and the principle of beneficence by failing to empower patients to actively participate in their own care and disease management, thereby increasing their risk of adverse events. Professionals should adopt a decision-making framework that begins with a thorough understanding of the audit findings and their implications for patient care. This involves critically evaluating current practices against established European guidelines and regulatory requirements. The next step is to identify specific areas for improvement, prioritizing those with the greatest potential impact on patient safety and outcomes. This should be followed by the development and implementation of a structured action plan, including clear objectives, measurable outcomes, and defined responsibilities. Continuous monitoring and evaluation of the implemented changes are crucial to ensure sustained improvement and compliance with EDC standards. Question 15. Quality control measures reveal that a cardiologist has been prescribing a novel investigational drug for a specific, severe form of refractory heart failure, a condition for which the drug has not yet received marketing authorization from the European Medicines Agency, EMA. The cardiologist believes the drug shows significant promise based on early research and anecdotal evidence from international conferences, and has not formally sought approval for compassionate use or off-label prescription through the appropriate national competent authority. What is the most appropriate course of action for the cardiologist in this situation, considering European Union regulatory frameworks and cardiology practice guidelines? Option A. Inform the patient about the off-label nature of the treatment and continue prescribing the drug, relying on the physician's clinical judgment and the patient's consent to proceed without formal regulatory approval. Option B. Continue prescribing the investigational drug as the patient is showing positive clinical responses, and document the rationale in the patient's medical record, assuming that the positive outcomes justify the deviation from standard regulatory procedures. Option C. Immediately discontinue the investigational drug and revert to standard therapies, while initiating a formal application for compassionate use or off-label authorization if the patient's condition remains critical and alternative treatments are exhausted. Option D. Seek retrospective approval from the EMA for the off-label use of the drug, explaining the positive patient outcomes as justification for the initial lack of formal authorization. Correct answer is C. Immediately discontinue the investigational drug and revert to standard therapies, while initiating a formal application for compassionate use or off-label authorization if the patient's condition remains critical and alternative treatments are exhausted. Explanation. This scenario presents a professional challenge due to the inherent conflict between a physician's clinical judgment and the availability of a novel, potentially beneficial, but not yet fully established therapeutic agent. The physician must navigate the ethical imperative to provide the best possible care for their patient while adhering to the rigorous standards of evidence-based medicine and regulatory approval processes within the European Union, as governed by the European Medicines Agency, EMA, and relevant national competent authorities. The challenge lies in balancing the desire to offer cutting-edge treatment with the responsibility to ensure patient safety and the efficacy of the intervention, which are paramount under EU pharmaceutical regulations and cardiology practice guidelines. The correct approach represents best professional practice because it prioritizes patient well-being and adherence to established regulatory pathways. Seeking an off-label use authorization or compassionate use program, when appropriate and supported by preliminary data, allows for the controlled and monitored administration of a drug outside its approved indications. This process involves thorough ethical review, informed consent, and a commitment to data collection, aligning with the principles of good clinical practice and the regulatory framework designed to protect public health. It ensures that any deviation from standard practice is justified, transparent, and subject to oversight, thereby upholding the trust placed in healthcare professionals. An incorrect approach that involves prescribing the drug without proper authorization or documented justification would represent a significant regulatory and ethical failure. This could lead to serious patient harm if the drug proves ineffective or has unforeseen side effects, and it bypasses the safety nets established by regulatory bodies. Such an action would violate the principles of evidence-based medicine, potentially expose the physician to legal and professional sanctions, and undermine the integrity of the pharmaceutical approval system. Furthermore, failing to obtain informed consent regarding the off-label nature of the prescription would be a clear breach of patient autonomy and a violation of ethical medical practice. The professional decision-making process for similar situations should involve a systematic evaluation of the available evidence for the novel therapy, a thorough assessment of the individual patient's clinical condition and unmet needs, and a comprehensive understanding of the relevant regulatory landscape. This includes consulting with colleagues, seeking expert opinions, and exploring all legitimate avenues for accessing investigational or off-label treatments. Transparency with the patient, including a detailed discussion of risks, benefits, and alternatives, is crucial. Adherence to institutional policies and national/European guidelines for compassionate use or off-label prescribing is essential to ensure both patient safety and regulatory compliance. Question 16. Implementation of a novel, minimally invasive technique for left ventricular access during cardiac catheterization, aiming to reduce fluoroscopy time and contrast volume, requires a structured approach to ensure its safe and effective integration into routine practice within a European cardiology department. Which of the following strategies best aligns with the principles of process optimization and regulatory compliance for such an implementation? Option A. Implement the new technique solely based on the recommendation of the most experienced interventional cardiologist in the department, without formal evaluation or data collection. Option B. Conduct a prospective pilot study involving a select group of patients to evaluate the new technique's feasibility, safety profile, and impact on key procedural metrics, followed by a data-driven decision on wider adoption and protocol refinement. Option C. Immediately adopt the new technique for all eligible patients based on promising preliminary data from a single overseas institution, assuming it will yield similar benefits. Option D. Prioritize the implementation of the new technique based on its potential to reduce consumable costs, deferring comprehensive clinical outcome assessment until after widespread adoption. The correct answer is B. Conduct a prospective pilot study involving a select group of patients to evaluate the new technique's feasibility, safety profile, and impact on key procedural metrics, followed by a data-driven decision on wider adoption and protocol refinement. Explanation. The scenario presents a challenge in optimizing the workflow for cardiac catheterization and angiography procedures within a European cardiology setting, balancing patient safety, procedural efficiency, and adherence to evolving clinical guidelines. The professional challenge lies in integrating new technologies or protocols without compromising the quality of care or introducing new risks, while also ensuring that all team members are adequately trained and that resource allocation is efficient. Careful judgment is required to select an approach that demonstrably improves outcomes and processes, aligning with the principles of evidence-based medicine and patient-centered care. The correct approach represents best professional practice because it prioritizes a systematic, evidence-based evaluation of a new protocol. This involves a pilot study to assess its impact on key performance indicators such as procedure time, complication rates, radiation exposure, and patient satisfaction. This iterative process allows for data-driven refinement before widespread implementation, ensuring that the changes are safe, effective, and aligned with the European Diploma in Cardiology's emphasis on continuous quality improvement and adherence to established European guidelines for interventional cardiology. It also fosters a culture of learning and adaptation within the cardiology department. An incorrect approach that involves immediate, unverified implementation of a new protocol without prior assessment poses significant regulatory and ethical risks. It fails to uphold the duty of care to patients by potentially introducing unknown complications or inefficiencies. Ethically, it bypasses the principle of beneficence and non-maleficence by not adequately ensuring the safety and benefit of the proposed change. From a regulatory standpoint, it could be seen as a failure to adhere to quality assurance standards expected within European healthcare systems, which often mandate evidence-based practice and risk assessment for new procedures or technologies. Another incorrect approach, focusing solely on cost reduction without a comprehensive evaluation of clinical impact, is professionally unacceptable. While financial prudence is important, it cannot supersede patient safety and procedural efficacy. This approach risks compromising the quality of care, potentially leading to poorer patient outcomes and increased long-term costs due to complications or suboptimal treatment. It also disregards the ethical imperative to provide the best possible care within available resources, rather than simply the cheapest. A further incorrect approach, relying solely on anecdotal evidence or the experience of a single senior clinician without broader validation, is also problematic. While individual expertise is valuable, it is not a substitute for rigorous, systematic evaluation. This approach lacks the objectivity and data required to ensure that the proposed changes are universally beneficial and safe for all patients, and it may not align with the consensus of European interventional cardiology practice. A professional decision-making process for similar situations should involve a structured approach. 1. Identify the need for process optimization based on performance data, new research, or emerging technologies. 2. Formulate a clear objective for the proposed change. 3. Conduct a thorough literature review and consult relevant European guidelines. 4. Design a pilot study or phased implementation plan with defined metrics for success. 5. Collect and analyze data rigorously. 6. Refine the protocol based on findings. 7. Implement the optimized protocol department-wide with appropriate training and ongoing monitoring. 8. Regularly review and update the protocol as new evidence emerges. Question 17. Benchmark analysis indicates that a 65-year-old male patient with atrial fibrillation is being initiated on warfarin for stroke prevention. Pre-treatment genetic testing reveals he is heterozygous for the CYP2C9*2 allele and homozygous for the VCORC1-1639G, a polymorphism. Considering European guidelines and best practices for pharmacogenomic integration in cardiology, what is the most appropriate initial management strategy? Option A. Initiate warfarin as standard dose and disregard the genetic findings as they are not definitive predictors of warfarin response. Option B. Initiate warfarin as standard starting dose, closely monitoring INR and adjusting as clinically indicated. While acknowledging the genetic findings may suggest a lower initial dose is likely needed. Option C. Initiate warfarin at a significantly reduced dose based solely on the identified CYP2C9 and VCORC1 genotypes, without further clinical consideration. Option D. Delay warfarin initiation until further genetic testing for other potential drug-metabolizing enzymes is completed. Correct answer is B. Initiate warfarin as standard starting dose, closely monitoring INR and adjusting as clinically indicated. While acknowledging the genetic findings may suggest a lower initial dose is likely needed. Explanation. Scenario analysis. This scenario presents a common challenge in modern cardiology practice, integrating pharmacogenomic data into clinical decision-making for patients on anticoagulant therapy. The challenge lies in balancing the potential benefits of personalized medicine with the need for evidence-based practice, patient safety, and adherence to evolving regulatory guidance. Clinicians must navigate the complexities of interpreting genetic test results, understanding their clinical utility, and communicating these findings effectively to patients, all while ensuring compliance with European guidelines and ethical principles. The absence of universally established clinical guidelines for every pharmacogenomic marker adds to the complexity, requiring careful judgment. Correct approach analysis. The correct approach involves a comprehensive assessment that considers the patient's clinical profile, the specific genetic variant identified, and the available evidence supporting its impact on drug response and clinical outcomes. This aligns with the European Society of Cardiology (ESC) recommendations and broader European regulatory frameworks that emphasize evidence-based medicine and patient-centered care. Specifically, for anticoagulation, understanding the implications of CYP2C9 and VCORC1 genotypes for warfarin dosing is well established and supported by guidelines. When considering other markers, a cautious approach that prioritizes robust clinical evidence and expert consensus is paramount. This ensures that treatment decisions are not solely driven by genetic information, but are integrated into a holistic understanding of the patient's risk and benefit profile, adhering to the principle of do no harm and optimizing therapeutic efficacy. Incorrect approach is analysis. One incorrect approach is to disregard pharmacogenomic findings entirely, even when they are well established and have clear clinical implications for drug metabolism or efficacy. This failure to incorporate potentially valuable personalized information can lead to suboptimal treatment, increased risk of adverse events, or reduced therapeutic benefit, contravening the principles of personalized medicine and potentially violating ethical obligations to provide the best possible care. Another incorrect approach is to over-rely on novel or poorly validated pharmacogenomic markers without sufficient clinical evidence to support their impact on therapeutic outcomes. This can lead to unnecessary treatment modifications, patient anxiety, and increased healthcare costs without a demonstrable improvement in patient care. It risks deviating from evidence-based practice and could be seen as a failure to adhere to the precautionary principle inherent in medical decision-making. A third incorrect approach is to make treatment decisions based solely on genetic information without considering the patient's overall clinical picture, including comorbidities, concomitant medications, and patient preferences. This reductionist view of patient care ignores the multifactorial nature of disease and treatment response, potentially leading to inappropriate or even harmful therapeutic choices. It fails to uphold the ethical imperative of holistic patient assessment and shared decision-making. Professional reasoning. Professionals should adopt a systematic decision-making framework when encountering pharmacogenomic data in cardiology. This framework should include 1. Clinical assessment. Thoroughly evaluate the patient's medical history, current medications, comorbidities, and risk factors. 2. Genetic data interpretation. Understand the specific genetic variant, its known association with drug metabolism or response, and the strength of the evidence supporting this association. 3. Evidence review. Consult relevant European guidelines, e.g., ESC, peer-reviewed literature, and expert consensus statements regarding the clinical utility of the identified pharmacogenomic marker in the context of the specific medication and patient. 4. Risk-benefit analysis. Weigh the potential benefits of personalized therapy against the risks of adverse events and the limitations of current evidence. 5. Patient communication and shared decision-making. Discuss the genetic findings, their implications, and treatment options with the patient, ensuring they understand the information and are involved in the decision-making process. 6. Documentation. Meticulously document the genetic findings, the rationale for treatment decisions, and the patient's input. Question 18. System analysis indicates a 65-year-old male patient with a history of paroxysmal atrial fibrillation and heart failure with reduced ejection fraction, LVEF 30%, presence for management. He experiences frequent symptomatic episodes of atrial fibrillation despite optimal medical therapy for heart failure. The physician is considering initiating an antiarrhythmic drug for rhythm control. Which of the following approaches represents the most appropriate initial pharmacological strategy, considering the patient's underlying cardiac condition and the need for effective and safe rhythm control? Option A. Initiate amiodarone, carefully monitoring for potential extracardiac side effects. Option B. Prescribe flecainide to effectively suppress atrial fibrillation episodes. Option C. Focus on optimizing rate control with a non-dihydropyridine calcium channel blocker and defer rhythm control. Option D. Administer quinidine to restore sinus rhythm and prevent recurrence. The correct answer is A. Initiate amiodarone, carefully monitoring for potential extracardiac side effects. Explanation. Scenario analysis. This scenario presents a common clinical challenge in cardiology, managing a patient with paroxysmal atrial fibrillation and a history of heart failure with reduced ejection fraction, HFrF. The complexity arises from the need to select an antiarrhythmic agent that is both effective in rhythm control and safe in the context of impaired left ventricular function. Many antiarrhythmic drugs have proarrhythmic potential or negative inotropic effects that can exacerbate heart failure, making the risk-benefit assessment critical. The European Diploma in Cardiology, EDC, framework emphasizes evidence-based practice and adherence to guidelines, requiring a deep understanding of drug classifications, their electrophysiological mechanisms, and their specific contraindications or precautions in various cardiac conditions. Correct approach analysis. The correct approach involves selecting an antiarrhythmic drug that is recognized for its safety profile in patients with HFrEF and is effective for rate or rhythm control in atrial fibrillation. Amiodarone is a class Roman III antiarrhythmic that, despite its potential for extracardiac side effects, has a well-established role in maintaining sinus rhythm in patients with structural heart disease, including HFrEF, and is often considered a first-line agent for rhythm control in this population when indicated. Its efficacy in preventing atrial fibrillation recurrence and its relatively neutral or even beneficial effects on cardiac function in some HFrEF patients, compared to other agents, support its use. Adherence to EDC principles means prioritizing agents with robust clinical trial data supporting their use in this specific patient profile. Balancing efficacy with safety. Incorrect approach is analysis. Choosing a class IK antiarrhythmic, such as flecainide or propafenone, would be an incorrect approach. These drugs are contraindicated in patients with structural heart disease, including HFrEF, due to their significant proarrhythmic potential and negative inotropic effects, which can lead to increased mortality. This directly violates the safety principles emphasized in cardiology practice and by the EDC. Similarly, selecting a class IA antiarrhythmic like quinidine or disopiramide would be inappropriate. While effective for rhythm control, these agents also possess negative inotropic properties and can prolong the QT interval, increasing the risk of torsades de pointes, especially in patients with underlying cardiac dysfunction. Their use in HFrEF is generally discouraged due to these risks. Finally, relying solely on rate control with beta blockers or calcium channel blockers without considering rhythm control when indicated, or choosing an agent with known negative inotropic effects without careful consideration of the HFrEF, represents a failure to apply a comprehensive risk-benefit assessment as expected within the EDC framework. While rate control is a valid strategy, the question implies a need for rhythm control, and the choice of agent must be guided by safety in HFrEF. Professional reasoning. Professionals managing such a case should first assess the patient's hemodynamic stability and symptoms related to atrial fibrillation. The decision between rate and rhythm control should be guided by current European Society of Cardiology (ESC) guidelines for atrial fibrillation management, considering patient preference, symptom burden, and risk of stroke. If rhythm control is chosen, the next critical step is to select an antiarrhythmic agent based on the patient's comorbidities, particularly the presence of HFrEF. A thorough review of the drug's electrophysiological properties, known side effects, and contraindications in the context of HFrEF is paramount. Consultation with electrophysiologists or heart failure specialists may be beneficial. The decision-making process must be documented, including the rationale for the chosen agent and the discussion of risks and benefits with the patient. Question 19. Cost-benefit analysis shows that a novel investigational therapy for a specific cardiac condition demonstrates promising early-stage efficacy in a small pilot study, potentially offering a significant improvement over current standard treatments for a subset of patients with refractory disease. However, this therapy is not yet approved by the European Medicines Agency, EMA, and is not widely available outside of clinical trials. Considering the European Diploma in Cardiology's emphasis on evidence-based practice and patient safety, what is the most appropriate course of action for a cardiologist presented with a patient who is a potential candidate for this therapy? Option A. Advise the patient that no further treatment options are available, as the therapy is not yet approved and therefore not considered a viable option. Option B. Enroll the patient in a recognized clinical trial for the investigational therapy, provided they meet the trial's inclusion criteria, and after a thorough informed consent process. Option C. Prioritize the cost-benefit analysis of the investigational therapy from a healthcare system perspective, and only consider it if it proves to be significantly more cost-effective than existing treatments. Option D. Prescribe the investigational therapy off-label immediately, based on the promising pilot study results, to offer the patient the best chance of improvement. The correct answer is B. Enroll the patient in a recognized clinical trial for the investigational therapy, provided they meet the trial's inclusion criteria, and after a thorough informed consent process. Explanation. Scenario analysis. This scenario presents a common challenge in modern cardiology practice, balancing the potential benefits of novel, emerging therapies with the established standards of care and the rigorous evidence requirements of regulatory bodies. The physician must navigate the ethical imperative to offer potentially life-saving treatments against the responsibility to ensure patient safety and avoid premature adoption of unproven interventions. The professional challenge lies in discerning when the evidence for an emerging therapy is sufficiently robust to justify its use, even if not yet widely adopted or fully reimbursed, while also respecting the established guidelines and the financial implications for both the patient and the healthcare system. This requires a deep understanding of the current research landscape, the regulatory approval process, and the principles of evidence-based medicine. Correct approach analysis. The correct approach involves a thorough, individualized assessment of the patient's specific clinical situation, a comprehensive review of the available evidence for the emerging therapy, and a transparent discussion with the patient about the risks, benefits, and uncertainties. This aligns with the European Diploma in Cardiology's emphasis on evidence-based practice and patient-centered care. Specifically, it requires consulting the latest European Society of Cardiology (ESC) guidelines, which are the primary regulatory and clinical framework for cardiology practice within the European context. If the emerging therapy is being investigated in a clinical trial that is recognized and approved by relevant European regulatory authorities, e.g., EMA for drug approval, national competent authorities for clinical trial authorization, and the patient meets the trial's inclusion criteria, enrolling the patient in the trial represents the most ethically and regulatorily sound path. This ensures the therapy is administered under strict protocols, with continuous monitoring, and contributes to the body of evidence needed for its eventual broader adoption. It also respects the principle of informed consent, as the patient will be fully apprised of the experimental nature of the treatment. Incorrect approaches analysis. One incorrect approach would be to immediately prescribe the emerging therapy outside of a clinical trial setting, based solely on preliminary positive data from a single, small study. This fails to adhere to the rigorous evidence requirements mandated by European regulatory frameworks and ESC guidelines, which emphasize the need for large-scale, randomized controlled trials to establish efficacy and safety. Such an approach risks exposing the patient to unknown harms and could be considered off-label use without sufficient justification, potentially leading to ethical and regulatory repercussions. Another incorrect approach would be to dismiss the emerging therapy entirely due to its experimental status, without considering its potential to address an unmet clinical need or improve outcomes for a specific patient. This could be seen as a failure to uphold the physician's duty to explore all reasonable treatment options and could lead to suboptimal patient care, especially if the patient has exhausted standard treatment options. It also neglects the importance of clinical trials in advancing medical knowledge and offering hope to patients with limited alternatives. A third incorrect approach would be to prioritize the cost-benefit analysis from a purely financial perspective, without adequately weighing the potential clinical benefits and patient well-being. While cost-effectiveness is a consideration in healthcare, it should not override the primary ethical obligation to provide the best possible care for the individual patient, especially when dealing with potentially life-altering conditions. This approach could lead to denying patients access to potentially beneficial treatments based on short-term economic considerations rather than long-term patient outcomes. Professional reasoning. Professionals should approach such dilemmas by first consulting the most current and relevant European guidelines, e.g., ESC guidelines. They should then actively seek out information on ongoing clinical trials for emerging therapies, verifying their regulatory approval and ethical oversight. A structured approach to patient assessment, including a thorough understanding of their individual disease profile and treatment history, is crucial. Open and honest communication with the patient, detailing the evidence base, potential risks, benefits, and alternatives is paramount. If a relevant and ethically sound clinical trial is available, it should be presented as a primary option. If not, the decision to use an emerging therapy off-label requires careful consideration of the available evidence, potential benefits, and significant risks, always prioritizing patient safety and informed consent within the existing regulatory and ethical framework. Question 20. Investigation of a 65-year-old male patient with new-onset exertional dyspnea and a history of hypertension and hyperlipidemia, but no known coronary artery disease, requires careful consideration of stress testing indications and methodologies. Given the patient's presentation and risk factors, which of the following approaches best aligns with current European cardiology guidelines for risk assessment and diagnostic strategy? Option A. Recommend a period of watchful waiting and lifestyle modification, deferring any stress testing until symptoms significantly worsen. Option B. Proceed directly to coronary angiography without a prior non-invasive stress test, given the patient's age and risk factors for coronary artery disease. Option C. Initiate exercise electrocardiography stress testing as the first-line investigation, assuming it is the most cost-effective and widely available method for assessing exertional symptoms. Option D. Conduct a comprehensive pre-stress test risk stratification, including a detailed clinical assessment for contraindications and consideration of the most appropriate stress imaging modality, e.g., stress echocardiography or myocardial perfusion imaging, based on the diagnostic question and patient factors. The correct answer is C. Initiate exercise electrocardiography, stress testing as the first-line investigation, assuming it is the most cost-effective and widely available method for assessing exertional symptoms. Explanation. This scenario presents a professional challenge due to the need to balance the diagnostic utility of stress testing with the inherent risks, particularly in a patient with a complex cardiac history and potential contraindication. Careful judgment is required to select the most appropriate stress testing methodology that maximizes diagnostic yield while minimizing patient harm, adhering strictly to European guidelines for cardiology practice. The correct approach represents best professional practice because it prioritizes a comprehensive risk assessment and selects a stress testing modality that is tailored to the patient's specific clinical profile and the suspected underlying pathology. This aligns with the European Society of Cardiology (ESC) guidelines, which emphasize individualized patient assessment and the selection of stress tests based on clinical indications, contraindications, and the likelihood of significant coronary artery disease. The chosen method should offer sufficient diagnostic accuracy for the suspected condition without exposing the patient to undue risk. An incorrect approach that fails to adequately assess contraindications before initiating stress testing would represent a significant regulatory and ethical failure. This could lead to adverse events, such as arrhythmias, myocardial infarction, or even cardiac arrest, directly violating the principle of primum non nocere, first, do no harm. Furthermore, it would contravene professional standards and guidelines that mandate thorough pre-procedure evaluation. Another incorrect approach might involve selecting a stress testing modality that is overly aggressive or not indicated for the patient's specific symptoms or risk factors, leading to unnecessary patient discomfort, anxiety, and potential complications without a commensurate diagnostic benefit. This would be a failure of clinical judgment and resource utilization, potentially deviating from evidence-based practice as outlined in European cardiology recommendations. The professional decision-making process for similar situations should involve a systematic approach. 1. Thoroughly review the patient's medical history, including symptoms, comorbidities, previous investigations, and medications. 2. Identify the specific clinical question that the stress test aims to answer. 3. Evaluate the patient's risk profile for both the underlying cardiac condition and the stress testing procedure itself. 4. Consider all absolute and relative contraindications for each available stress testing modality. 5. Select the stress testing method that offers the highest diagnostic accuracy for the suspected condition, considering the patient's individual characteristics and risk factors, while adhering to established European guidelines. 6. Ensure appropriate patient preparation and monitoring throughout the procedure.